This is Heart Rhythm TV. I'm Juan Carlos Zerpa. And for today, for Global EP, I have Germany and London, Dr. Isabel Deisenhofer and Dr. Dhiraj Gupta. Welcome to the show.
Thank you.
Thanks
for having us.
It's nice having you both here. We just had a great session about what to do with AF recurrence after the third ablation.
Yeah.
3 times. What do we do now? What is the problem, Isabel? What do you think? Why do we have the recurrence? What gets you to have this problem again once you tried 2 times?
Yeah, I think it's a strategy problem because we know very well, okay, we can get 70, 80% of the patients out of AFib with pulmonary vein isolation. But what if pulmonary vein isolation fails, if this is just a PVI non-responder? And that's an unsolved question. And what we do then, and that's something that came out during the discussion, some centers already do more during the first or second ablation, and more over the third ablation. And then there's always the question, okay, after a third one, when I did already extensive ablation before, I tried everything. Should I really do a 4th one? Whereas there are some centers that really stick to PVI only for the first 1 or 2 ablations, and then of course you can venture into doing more and even more only after the 3rd ablation.
Yeah, this is a difficult question that we need to answer to. But Gira, when too much is too much? What do we do when you have all the veins isolated and you go for the 3rd round? What are you gonna do now?
Well, that's a very important point, isn't it? Because more and more we are finding that situation where patients come to the catheter laboratory, all the pulmonary veins are silent from before and they still have atrial fibrillation. And nobody really knows what to do. That was one of the things that came out in the debate, the paucity of data about what is the right strategy for these patients. And so everybody does their own thing. Somebody will isolate the posterior wall, somebody will isolate in the SPC. There was also some debate about isolating the left atrial appendage, but nobody really knows what to do. And I totally share your concern that if you ablate everything, you will be left with a probably sinus rhythm, but a non-contractile left atrium. So that won't help anybody. So I think it's an area which is controversial, and hence the debate, hence the full room at the session, but nobody really knows what to do. I think the important thing is that we need to have a randomized study in this space. Patients they deserve to be studied prospectively in a formal fashion rather than everybody just doing whatever they want to do.
But for randomizing, we're going to have so many variables because you have pulse field ablation, you have cryoablation, you have radiofrequency ablation, and what will be the best technique to do at this point? We have the evidence with pulse field ablation as first-line therapy. The evidence is coming about the long-standing, but how about recurrence? We don't know nothing about that.
True.
This is going to impact the cost, the economic issue too. What do you think about it?
I think that's an important point. First of all, in terms of the technology, there's no doubt that pulsed field ablation is going to be the future because it has made the procedure a lot quicker, a lot more predictable, a lot perhaps less dependent upon operator experience and skill. Also, there are some data showing that the durability of pulmonary vein isolation is better with some of these pulse field ablation technologies compared to focal radiofrequency. So I think we are going to find this to be more of a problem, as Isabel said, the non-pulmonary vein-based atrial fibrillation. Then the second question you raise is a very, very important one, which is the economic consequences of this. Do you keep ablating and ablating and ablating? Obviously, at some point, you have to realize that you're not going to win 100% of the time. You have to accept at some stage the patient will not be able to get back to sinus rhythm. So whether you have a strategy perhaps after 2 or 3 ablations where you will only really offer another ablation if the patient has gone from atrial fibrillation to atrial tachycardia or atrial flutter, then it's worthwhile offering them another ablation. If the patient is still in atrial fibrillation after 2 or 3 ablations, you might accept defeat, if that is the right word, and perhaps channel the patient to an alternative strategy such as a blatant pace.
When to throw the towel? When to stop ablating? And do we have another alternatives to treat this?
Yeah, I think the one thing is when to throw the towel, and the other one is, as Dhiraj says, what strategy to do as a PVI plus strategy. I'm not going to tease you, but tomorrow there's a late-breaking trial session, and we're going to present.
Don't miss the late breakers.
So exactly, maybe we're going to miss to present some alternative to doing just pragmatic empirical things, and the other one is, of course, when you've done a lot of damage, and I think that's really an important point that was raised again, when you've done already a lot of damage. I mean, I think it's not a strategy, not a fair strategy to the patient to say, you know what, no atrium, no atrial fibrillation.
How about pacing?
Yeah.
You have a space for pacing over there?
Yeah, I think that with the current technologies of physiological pacing, pace in a blade has also gained a new place, okay? And we could probably use that in these desperate situations where we really think that what is the profit of doing in another endocardial ablation, no profit visible, so let's go for this. So I think the debate today really reflected that complex question, and also I think that we have to go on a very individualized decision basis here, because it's every patient received a little bit of a different ablation strategy in the first 3 ones, so really have to look carefully at what was done before. Luigi pointed it out several times, and Musa also said, and it all depends on what did you do before.
And who wins the debate?
Well,
I wonder what Luigi did and what Dr. Mansour did.
It was a 50-50 split, really. I think that just again tells you that it was a very well thought out debate in terms of the program committee, because this is an important question. Nobody really knows what the answer is. But one thing is sure is that one size does not fit all. Every patient is different, and you have to base the decision on the patient. So if somebody has a massive left atrium, is very elderly, perhaps minimally symptomatic, you are going to perhaps accept defeat after just 2 attempts, or perhaps even after 1 attempt. If you say you go in and you find that the left atrium is completely scarred, you're never going to restore sinus rhythm. Whereas if somebody, as I said, is younger, the left atrium is not big, you manage to restore atrial fibrillation, you manage to change it to atrial flutter, then you perhaps will carry on even after the 3rd ablation. So one size does not fit all.
We got to control all desperate manners, to control all the rhythm and to avoid damage too.
Correct.
It was great having you both here.
It was a pleasure.
A pleasure of mine.
Thank you for having us.
Thank you for watching, and don't forget to watch the YouTube channel of Heart Rhythm TV in social media. Thank you.